Hello everybody, right from ESD Vienna. It's my absolute privilege, me, Dr. Sanghvi from Mumbai, would take this opportunity to introduce Professor Gian Paolo Fadini from Italy. Sir, it's an absolute pleasure to have you over with us to discuss on your study on frequency, clinical characteristics, and outcomes associated with various definitions of remissions after initiation of GLP-1 RAs for our patients with type 2 diabetes. Before I jump to the questions, a short introduction about Sir. He's a prominent figure in endocrinology and metabolism, serving as a professor at University of Padua, and he is the leader in the laboratory of experimental diabetology at the Venetian Institute of Molecular Medicine. Sir has had huge contributions in focusing on diabetes complications, stem cells, angiogenesis. He has published over 380 articles with an impressive H index of 68, showcasing his impactful work. Pleasure to have you with us, sir. So, right to the first question, sir, can you kindly briefly summarize the key findings of your study in a way that is most relevant in today's diabetes care?
So thank you for introducing me and for the nice words. The study that I'm presenting today here in Vienna is about the remission that can be achieved in people with type 2 diabetes after initiation of a GLP-1 receptor agonist. We know that remission today is a highly topical issue because of the newer drugs that are becoming available that allow very good weight loss. And weight loss is supposed to be driving the mechanisms that allow achieving remission. And so for the young doctors that are approaching diabetes management today, it is very important to be aware that we should seek remission, that remission is achievable, and that GLP-1 RAs are particularly suitable for achieving such a state. What we did in our study is to use data from a huge retrospective study, which included kind of 14,000 patients with type 2 diabetes initiating a GLP-1 receptor agonist in Italy, and they were followed up for a mean of 4 years. Actually, some have a much longer follow-up, and this enabled us to look at long-term outcomes in terms of metabolic control, what happened after remission, even when remission is only transient, if there were sustained benefit over time, even after remission is no longer in place. And we also had the opportunity to look at long-term complications of these patients. And so what we did is took the data, look back retrospectively, check whether remission occurred or not after initiation of this class of medications, and then look at what happens of hemoglobin A1C, body weight, lipids, and some biomarkers of kidney function and complications over time. And we were able to describe the trajectory of the patients, the frequency of remission, how long remission lasted over time, and whether it was associated with sustained improvement in metabolic parameters and improvement in complications.
Okay, so now that's pretty impressive. So with diabetes and obesity actually blasting, and moreover, we see in our Asian population too that it is on a rise, and people weren't aware that obesity can be a disease. So we making aware about how important it is to not only manage diabetes but the obesity at the same time. So when we talk about remission, how would you like to put it as the simplest way, of remission, which we can use in our day-to-day routine practice when we talk to our patients in our clinics? So.
Yeah, this is an important question. Not all doctors are aware of the definition of remission, and especially for the youngest one, it is important to be aware of what we mean for type 2 diabetes remission. So the simplest definition has been proposed by a multi-society expert consensus a few years ago. And so basically we define remission when the patient has an hemoglobin A1C below 6.5%, which is 48 millimole per mole, for at least 3 months after stopping all diabetes medications. So this is very simple. It has a quite, accepted threshold for hemoglobin A1C, which is the diagnostic one for type 2 diabetes. It is a short time frame. Just 3 months are needed at the minimum for checking whether there is remission. And then the important concept is that we should stop all the medications in order to define whether a patient has achieved this remission status.
Okay. So, but when we talk about remission, you said that, we need an A1C below 6.5 for at least 3 months. So, are we looking at a particular class of patients, some particular characteristics like BMI or the duration of diabetes or age of the patient, which would predict some better chances of remission in those patients?
Yeah, this is a very good question, because we should be able to understand which patients have the highest probability of entering into the remission status, because otherwise we would be trying, to check remission for patients who are not particularly keen or candidate to get the status, and probably end up with problems. So what we found is that basically, irrespectively of the definition of remission, even if you change the definition of remission, the factors associated with remissions are always the same. There are a few key variables that identify the patients who have a greater probability, and these features are younger age, female sex, having a higher BMI at baseline, meaning that probably that specific type 2 diabetes is more obesity related than other forms that may be more beta cell dysfunction related. Patients who do not have a great complication burden, so they're in the earlier stages of the disease and they're only on metformin and maybe also GLP-1, but not aiming a complex diabetes pharmacotherapy. So, probably this is the phenotype of an early patient that has a greater probability of entering remission.
Exactly. So if we have patients who are on lower doses of medications or something, they can be motivated, but I'm sure you would agree on this, that sustainability is the key. We have to keep on motivating them in terms of the lifestyle changes, in addition to the pharmacotherapy. So, sir, coming on to the next question, that when we talk about remission or talk about treatment of diabetes during remission, do we completely stop it, or do we taper it down over a period of time so that the patient has good glycemic control along with weight reduction?
Yeah, I think this is probably the most important point when it comes to the definition of remission and its application in clinical practice, because based on the definition, we should completely stop the medications. And this can be problematic for some patients for a couple of reasons. First is that completely stopping medication suddenly, for example, if they are on 2 or 3 diabetes drugs, can be followed by a steep raise in hemoglobin A1C, which is not good for the patients. The second point is that patients may be taking diabetes drugs like SGLT2 inhibitors or GLP-1 receptor agonists, not only for their glycemic management, but also for the management of body weight, of course, and for reducing the risk of chronic complication or for secondary prevention of chronic complications. So let's think about patients who have chronic kidney disease or had a cardiovascular events. For them, the use of SGLT2 inhibitors and GLP-1 receptor agonists is supposed to convey protection against end organ damage. It is not only a matter of getting remission in terms of glycemic control. So it is very important. What I would like to suggest, which is not basically based on evidence or consensus, is that the drugs are stopped one by one. Okay, so we reduce the therapeutic burden to the patient. Then even maybe the dosages may be reduced before stopping completely. And for those patients who need the diabetes drugs for end organ protection, probably we should have a separate definition of remission, where these drugs can be continued. This is what we explored in our study. And in fact, the definition of remission that was associated with the best long-term preservation, protection against complications, is the definition of remission where you have the hemoglobin A1C at target for at least 3 months, but you can continue your previous glucose lowering medication, meaning that you're not allowed to introduce new medications. So this is probably a stable condition of very good glycemic control, stable over time, which grants end organ protection on the long run.
So that gets me to my next question. So that, in your experience or while during the study, how long did you see that the patients were in the remission period where they were either not on medications or maybe on a single molecule like a GLP-1 RA or an SGLT2 inhibitor?
Yeah, this is a disappointing point, okay, because the duration of remission is incredibly short. Even when we apply the less restrictive definition of remission, which allows continuing the glucose lowering medication, the duration is around 6 to 9 months.
Okay.
And so, with a stricter definition, which is the current standard, okay, that you have to stop all medications, the duration of remission status is less than 6 months. When you allow continuing at least some of the glucose lowering medication, the duration prolongs for up to 9 to 10 months, or something like that. So it is a transient status. Of course, on average, not for all patients, there are patients who maintain this status longer. But what is important to observe is that even when remission is transient, when it lasts only 6 to 9 months, there are long-term benefits, because what we do see is that A1C remains lower by about 1% in patients who achieved remission at any time during observation, and even when it's transient. So the A1C remains well controlled for up to 4 years. The same is for body weight, which remains lower after initiation of GLP-1 by about 2 kilos, which is not that much, but it is significant and it lasts over time. And also the complications are reduced. And it is important because it is a sort of legacy that this 6 to 9 months of remission status can have on the patient's long-term performance in terms of complication rates.
Absolutely. So even if they are on, say, 6 to 9 months of remission, they have a lot of benefits to look forward to in terms of not only the A1C, but looking at the complications due to diabetes. So that brings to my last question. So that when the patient is in remission period, that I mean, can he completely forget that he had diabetes, or should he be monitoring certain parameters like his A1C levels, his weight, his C-peptide over a certain period of time? So, how would we counsel our patients regarding that? So,
Yeah, this is a very practical issue which the doctors have to be aware of. Remission is not a cure of diabetes. As of today, we don't have cure of type 2 diabetes. So it's not a definite status. So the patients cannot forget about the disease. The disease is likely to be back in a few months or a few years. The patients need to be aware of that. The doctors need to be aware of that. So the doctors have to counsel the patient that they have still to check sometimes their glucose, to do what to know, to know what to do with their lifestyle, going on dieting, exercise. It is very important. And also we have to remind doctors that they have to their patients to check their A1C at least every 3 to 6 months, so at least 2, 3 times a year, in order to see whether they are still in the remission status or the disease is back because A1C is again above 6.5%. Then they will probably start again their medications. So going on with lifestyle, checking A1C on a regular basis, monitoring body weight is very important. I'm not sure the C-peptide is needed at this stage. Probably C-peptide, if it is available, is a good way of trying to understand whether the probability of remission is there or not. But checking A1C over time, once remission has been achieved, probably is not sustainable, it's not good. By checking hemoglobin A1C routinely is important.
So I think Sir has very well put it that, as we look at bringing down the medications, bring down the A1C, the risk of complications, do not forget that you have diabetes. Keep checking yourself at least 3 to 6 months. If you feel that your A1C is fluctuating, do consult your treating physician. And there would be a message to our doctors, our blooming doctors also, that they need to counsel their patients regarding remission. Sir, any one last sentence for us from you?
I think it is very important. This is a topical issue today. Remission is going to be on the spotlight for the next few years.
True.
So this is a very important, raising awareness on this point, understanding which are the ways and the trajectories that bring the patients to remission, but also being aware that remission is almost invariably a transient status.
Yeah. So I think with the awareness of diabetes and obesity increasing, the awareness of remission is also increasing, and with the new molecules treating obesity, many molecules coming in the pipeline, we have too much to look forward to. Thank you for joining us, Professor. It was a pleasure talking to you. Thank you so much once again.
Thank you.